Thank you very much, and good afternoon to everybody. And thank you all for being here today. Over the next 45 minutes, we are going to review primary hyperparathyroidism from a historical perspective as a journey over time. The outline for this presentation will include the definition of this disease, followed by the biochemical diagnosis of this condition. We'll describe the causes of primary hyperparathyroidism. We'll review the differential diagnosis for this disorder. We'll talk about the clinical manifestations that patients with this disease may have. We'll describe the surgical treatment, and finally, we'll review some of the therapeutic modalities from a medical perspective for patients who have this particular condition. So when we talk about hyperparathyroidism, we have to know the relevance and importance of calcium. Calcium is a very important element in our lives because it allows the electrical activity of the heart and the neurons, the skeletal and the cardiac muscle contractions, the hormonal secretion, the coagulation homeostasis, and the intracellular to cell and cell to cell communication. And as such, must be tightly regulated by an endocrine system, and that the endocrine system is controlled by two different important hormones. One is parathyroid hormone, or PTH, and two is vitamin D, in particular calcitriol. So let's review a little bit the regulation of the systemic calcium homeostasis. This one has to do with the activation of different cells located in the bones, in the kidneys, in the intestine by these different hormones. And everything starts with the concentrations of calcium in plasma. When the concentrations of calcium in plasma are high, they are going to send a message to the parathyroid glands that indicate that they have to decrease the production of PTH. When the concentrations of calcium in plasma are low, they are going to activate the parathyroid glands to increase the synthesis and secretion of parathyroid hormone. PTH is then produced by 4, and some people 5, 6, or even 7 parathyroid glands, and the action of PTH will have to do with the activity in two different organs, the skeletal tissue and the kidneys. In the case of the bone, the parathyroid hormone is going to activate the osteoblast. The osteoblasts have receptors that are going to later on induce the activation of the osteoclast in order to induce bone turnover. The bone turnover will move calcium that is deposited in the skeleton into the plasma in order to raise the concentrations of calcium in that particular tissue. In the case of the kidneys, the parathyroid hormone is going to work mainly in the proximal part of the kidney, in which is going to activate the alpha-1 hydroxylase in order to produce calcitriol, or 1,25-dihydroxyvitamin D3. This one will work later in the intestine, inducing the absorption of calcium coming from our diet. At the same time, in the proximal part of the tubule, the parathyroid hormone is going to decrease the reabsorption of phosphate, and in the distal part of the tubule in the kidney is going to increase the calcium reabsorption. Together then, parathyroid hormone and calcitriol are going to move calcium into the plasma, keeping the concentrations of calcium in good numbers whenever is needed according to our metabolic needs. Now, primary hyperparathyroidism is the most common endocrine disorder that we see in clinical practice in this particular endocrine system. The definition of primary hyperparathyroidism is the one of a syndrome that is characterized by an excessive secretion of parathyroid hormone that is going to lead to hypercalcemia. Primary hyperparathyroidism is the most common cause of hypercalcemia that we have in clinical practice, and is one of the top 5 endocrine conditions in clinical practice, at least in the United States and many other countries around the world. The biochemical diagnosis of primary hyperparathyroidism has to do with two different aspects. Number one, we have calcium levels that are above the upper limits of normality, and number two, the parathyroid hormone levels are also above the upper limits of normality. In addition, patients may have some surrogate biochemical markers that can support the diagnosis of primary hyperparathyroidism, and they include hypophosphatemia, elevated alkaline phosphatase, and elevated calcitriol that you may see in several patients who have this disease. Not in everybody, but in many of these patients you will see it. What are the causes of primary hyperparathyroidism? In about 80% of cases, primary hyperparathyroidism is caused by a solitary benign parathyroid adenoma. This one is usually sporadic, is not usually associated with a familiar predisposition. Then you may see multiple parathyroid adenomas that are the cause of primary hyperparathyroidism in about 2 to 4% of cases. Multiple parathyroid adenomas may be sporadic or may be familial. The third important cause of primary hyperparathyroidism is the parathyroid hyperplasia. This one is responsible for 15% of cases and is usually hereditary. And when hereditary, is mainly caused by multiple endocrine neoplasia type 1 and multiple endocrine neoplasia type 2A syndromes. Finally, parathyroid cancer, this is a rare cause of primary hyperparathyroidism, is an aggressive one, is responsible for 0.5 to 1% of total cases of primary hyperparathyroidism. Some of them are sporadic, some of them are familiar, and whenever they are familiar, they are associated with inactivating mutations of the parafibromin gene, predisposing to the hyperparathyroid jaw tumor syndrome that also predisposes to bone tumors located in the jaw, osteomas, as well as Wilms tumors located in the kidney. The differential diagnosis of primary hyperparathyroidism is presented here in this graphic, in which you have a Cartesian graphic in which in the x-axis you will see the concentrations of calcium in plasma in milligrams per deciliter, and in the y-axis the concentrations of parathyroid hormone in picograms per ml. In green, you will see patients who have normal calcium and PTH values, and in other colors, you will see patients who have abnormalities in this particular endocrine system. What are the differential diagnoses for primary hyperparathyroidism? Perhaps the largest one is represented by this area in the blue color. So here we have patients who have primary hyperparathyroidism. Most of them, 50% of them, exhibit calcium levels in plasma that are mildly elevated, associated with mild elevations of parathyroid hormone. You may see in these patients, however, a broad spectrum of clinical presentations. Sometimes you will see patients who have a very pronounced or robust hypercalcemia associated with not very high levels of parathyroid hormone in blood, or vice versa. You may see patients who have very high levels of PTH with minimally elevated calcium levels in plasma. So the spectrum of clinical presentation of primary hyperparathyroidism is quite big. Another important differential diagnosis here is the one that you see in pink, the hypercalcemia of malignancy. The hypercalcemia of malignancy may be caused by an increased production of parathyroid hormone-related peptide that happens in 80% of cases, osteolysis, which is about 19 to 20% of cases, and occasionally because of an increased production of calcitriol by tumors such as lymphomas or kidney cancer, and rarely by the ectopic production of PTH. The characteristic of most patients who have hypercalcemia of malignancy is that the calcium levels are quite high, and the parathyroid hormone levels, with the exception of those tumors that produce PTH, are going to be very low. This is a very severe type of hypercalcemia in clinical practice. Another important differential diagnosis, which is quite common in clinical practice, and you see it in yellow, is the vitamin D deficiency. Patients with vitamin D deficiency will have calcium levels that are usually in the lower limits of normality or below normal, in association with mild elevations of parathyroid hormone. And finally, another important differential diagnosis is represented here in light blue by kidney failure. Patients with kidney failure may develop secondary types of hyperparathyroidism characterized by very high values of PTH with calcium levels that are usually in the lower limits of normality or just below normal. Another important differential diagnosis for the patient who has a primary hyperparathyroidism, and perhaps the most difficult one to establish, what we call the troublemaker, is what we call familial hypocalciuric hypercalcemia. What is this condition? Familial hypocalciuric hypercalcemia is a condition that in clinical practice is caused by inactivating mutations of the calcium sensing receptor. In this graphic, you can see in the left side a normal calcium sensing receptor. This is a structure that is quite complex, characterized by 7 transmembrane domains associated with an extracellular tail and an intracellular tail that is quite long. In all these places, you may see mutations in the calcium sensing receptor that are going to alter the threshold for activation of this one depending on the calcium concentrations. And when those mutations happen, you will need to have higher levels of calcium in order to decrease the production of parathyroid hormone in plasma. Now, is this a disease? Well, we are going to review that from a clinical perspective. This is a condition that is autosomal dominant. It's characterized by inactivating mutations that happen generation after generation in several members of the same family. For most part, especially now, patients in the families that are affected by this condition usually have a history of hypercalcemia. They have hypocalciuria with mild hypercalcemia, and the levels of intact parathyroid hormone are normal to mildly elevated. These patients are asymptomatic, and if you look at the survival rates of these patients, they are exactly equal to the ones that we see in the general population. So is this a disease? The answer is not. This is a condition, and as such, we don't need to treat it in any way. This is just one way in which some human beings are. Where is this condition in the graphic of differential diagnosis of primary hyperparathyroidism? It's located in that area. Patients who have calcium levels that are mildly elevated in plasma in association with parathyroid hormone levels that are mildly elevated to numbers that are just located around the upper limits of normality. How do you differentiate in between benign familial hypercalcemia, hypocalciuria from hyperparathyroidism? Well, you can do it from a biochemical perspective. You simply look at the ratio of calcium to creatinine clearance, and whenever this ratio is lower than 0.01, that one clearly suggests that you are facing someone who has a benign familial hypercalcemia, hypocalciuria disease. Now let's talk about the historical aspects of primary hyperparathyroidism. This is a condition that, similar to others, is very interesting from the historical perspective because the way we practice on it has markedly changed thanks to the introduction of technology. How was primary hyperparathyroidism in the United States, as well as many different countries around the world, before 1970? The best description of this disease was the one that you see here, published in the New England Journal of Medicine in 1966. Primary hyperparathyroidism is a very rare, very dramatic disorder of the calcium metabolism. Why? This is the classical presentation of someone who had primary hyperparathyroidism before the 70s. This is someone who had a very pronounced or robust hypercalcemia with calcium values of 16.6. The patient had hypophosphatemia. The intact parathyroid hormones are markedly elevated, as you can see in this table. The disease in these patients was likely present for several years, even decades, before the diagnosis was made. And because of that, clinically speaking, a lot of toxicity because of parathyroid hormone activity was noted in the target organs. What are those target organs? Well, we reviewed them before, and they include the skeleton and the kidneys. Let's review briefly what we see in the skeleton because of toxicity associated with parathyroid hormone. In the skeleton, as we have mentioned before, we are going to have an increased activation of the bone resorption, and these patients are going to have then destruction of the bone. And this is an example of someone who has a severe hyperparathyroidism. You can see lytic lesions located in the long bones that many times mimic the presentation of lytic metastases. They are not lytic metastases, they are just an example of parathyroid hormone toxicity. Another interesting example of how toxic parathyroid hormone could be if you let it work for a long, long time in the skeleton is what we call the acro-osteolysis. In these x-rays, you can see that in the distal bones of all fingers, there is a reduction in the size of the bone areas. And you can see that from a clinical perspective. When you look at the fingers of this patient, they are markedly shortened just because of the resorption of bone that you can see in those areas. The spine can be affected also by primary hyperparathyroidism, and these patients used to have what we call the Roger-Jersey sign. The Roger-Jersey sign is similar to the Roger-Jersey shirt that you see in the right side of this slide. And what it means is simply that the cortical part of the spine is very thickened because of an increased bone formation, and the central part, because of bone destruction, is markedly decreasing bone density. These are patients who have an increased bone turnover. Another important clinical finding, radiographically speaking, is the clavicle distal resorption, or the pencil sign that we may see in clinical practice rarely, as well as the presence of brown tumors located, for instance, here in the pelvic area. In addition, patients may have the classical abnormalities related to an increased bone turnover in the skull. This is the salt and pepper clinical manifestation of primary hyperparathyroidism. And from a clinical perspective, you can see how this condition was in clinical practice before the 70s. This is a young man who initially looked quite healthy, and then after many years of being exposed to an increased production of parathyroid hormone without control, he developed brown tumors located in the jaw. He lost many of his teeth as a consequence of the growth of the brown tumors. If you look at his right arm, you see a fracture here. The patient was having osteoporosis in that particular area. There is a brown tumor in that area. And if you look at the clavicles, they are markedly shortened in size. In someone most recently evaluated with primary hyperparathyroidism, you can see how the patient has lost his shoulders. You don't see shoulders, and if you look at the chest is also quite small. This is someone who was complaining of shortness of breath because of the reduction of the skeletal tissue located in the ribs. The kidneys were the other important target of the actions of parathyroid hormone whenever toxic. And in the kidneys, parathyroid hormone may predispose to hypercalciuria, kidney stones in about 60% of patients in those times, nephrocalcinosis, a reduced glomerular filtration rate, and finally, renal failure. In addition, patients with severe primary hyperparathyroidism may also present with other clinical manifestations. Because of the fibrosis that they develop in the bone marrow, they may have bone marrow insufficiency, and these patients may have had anemia, leukopenia, or thrombocytopenia. Patients may have had neuromuscular deficiency with peripheral neuropathy and muscle weakness, neurocognitive features such as depression, cognitive dysfunction, anxiety, as well as gastrointestinal complications, mainly peptic acid disease, and perhaps an increased rate for cardiovascular disease predisposing to angina, heart attacks, and congestive heart failure. However, the history of primary hyperparathyroidism changed after the 70s. And why it changed? Simply because it was introduced into clinical practice the multi-channel autoanalyzer that was able to measure in everybody the calcium levels in plasma. And the primary hyperparathyroidism that we are now used to see are cases that are not as severe as the ones that I just presented to you. So what is the history of hyperparathyroidism after the 70s? You can see it in this table. This is a particular patient who has the classical presentation we currently see. Someone who has a mild degree of hypercalcemia, calcium of 10.7 milligrams per deciliter, with normal phosphate, intact parathyroid hormone mildly elevated, and with values of calcitriol, urinary calcium, alkaline phosphatase, and pyrilinks, markers for destruction, that are normal or located close to the upper limits of normality. When you look at the incidence of different issues abnormal in the context of primary hyperparathyroidism, you can see here how they presented before 1970 in red and after 1970 in yellow. If you look at the skeletal disease, before 1970, about 23% of patients with primary hyperparathyroidism will have severe bone manifestations. After 1970, only 2% of them may have it. In the case of kidney stones, before 1970, 60% of them had kidney issues. After 1970, about 20% of patients with primary hyperparathyroidism were having some kidney abnormalities. And of interest, because of the discovery of primary hyperparathyroidism accidentally by the autoanalyzer, the incidence after 1970 of this condition increased. And whatever was considered initially a rare disease is no longer rare and is becoming one of the most common endocrine conditions in clinical practice. Another important aspect, after 1970, instead of seeing all those symptoms, what we see is mainly patients who have a mild asymptomatic hyperparathyroidism as the most common clinical presentation of this disease. Which are currently the most common manifestations of primary hyperparathyroidism when these patients have symptoms? When they have symptoms, the manifestations are rather constitutional than specific, and they are presented here. And they include, for instance, fatigue or exhaustion, muscle, joint, and bone pain, back pain, weakness, polydipsia and polyuria, constipation, depression, memory loss, and itching. And they are the most common one in clinical practice. And when the patients go to see the primary care provider, many times they describe it, but the primary care provider is not able to say exactly what is happening because they are not as specific as they used to be before. Another important aspect, this is a disease. Is primary hyperparathyroidism a condition that is going to alter the survival of patients who have it? Well, according to this study, according to the situation right now, where most cases are mild, well, apparently, in most of our patients, we are not going to see abnormalities in survival rates. And this is presented in this very nice study published in 1998 by the Mayo Clinic in Minneapolis, in Rochester, Minnesota, where you can see in the upper part the expected survival rate for the general population and the observed survival rate of patients with primary hyperparathyroidism in the continuous line, and after a period of 5, 10, and 15 years, the survival rates are about the same. There is no statistical significant difference in between all of them. And what about surgery? Even despite of surgery, the surgery apparently didn't have an impact in patients who were having mild hyperparathyroidism in the survival rates. What is the conclusion of this? Do we have to do surgery in everybody who has primary hyperparathyroidism? Perhaps no. So that's why we talk about the indications for surgery in patients who have primary hyperparathyroidism in clinical practice. Not everybody who has this condition will need to have surgery. Who are the ones who need to have surgery? Of course, those patients who are symptomatic because they are having problems, and that implies that they have an increased presentation of nephrocalcinosis, nephrolithiasis, osteitis fibrosa cystica, altered mental status, and neuroconstitutional symptomatology. There are, however, some patients who may benefit in addition despite the fact that they are asymptomatic. Patients who, for instance, exhibit bone loss. Patients with primary hyperparathyroidism in clinical practice, in many cases, not in all, may exhibit a reduction of bone density at places such as the lumbar spine, the femoral neck, and the radius when you look at this graphic when compared with baseline that is represented here by the top line. So some patients who are asymptomatic may also benefit from treatment in regards to surgical intervention. So what are the indications for surgeries? According to the guidelines for parathyroid surgery published in the workshop in 2013, we consider now that the following patients who are asymptomatic will need to get surgery. Number one, patients who have calcium levels that are above 1 milligram per deciliter, the upper limits of normality. Number two, patients who have kidney abnormalities represented here by the creatinine clearance that is below 60 mLs per minute per 1.73 meters squared. Or patients who have nephrocalciuria with excretion of calcium higher than 400 milligrams per deciliter, or patients who radiographically and clinically speaking present with nephrocalcinosis and kidney stones. In regards to bone mineral density, as you know, this is a condition that may predispose to bone loss. So everybody who may have a T-score value of minus 2.5 at any site, the spine, the hips, or the wrist, may need to have a parathyroid surgery simply because they are more prone to develop surgery. And another one that is quite important, whenever someone presents with primary hyperparathyroidism, and when this individual is younger than 50 years of age, yes, that patient may need to have surgical resection of the disease. For people who are older than 50 years of age in the US, it's not proposed to do it as long as they are asymptomatic and do not have any of the other criteria present in clinical practice, saying that in the time, we expect that many of us as humans will live longer, and perhaps this is a parameter that may change later as a cutoff, because later on we may start seeing again the complications of patients who have not had surgery as long as we live, the disease continues. So how is the surgical procedure for patients who have primary hyperparathyroidism? We are going to talk about surgery before and after the 21st century. Surgery during the 20th century was quite interesting for patients with primary hyperparathyroidism. The decision for surgery relied exclusively on the surgeon, and it was told that the only localization study that was needed by a patient undergoing initial parathyroid surgery was simply to locate an experienced parathyroid surgeon. And the parathyroid surgeon had to open the neck and had to look at the parathyroid glands. He had to examine the 4 parathyroid glands, or as many as the patient had, in order to identify which ones were enlarged. Well, we don't do that any longer, and this is to the fact that parathyroid disease in most cases is just a single parathyroid adenoma, and in an effective manner, we can measure the parathyroid hormone levels after surgery in order to confirm that the surgery is quite effective in clinical practice. What we currently propose to do in most patients who have parathyroid disease is what we call a minimal invasive parathyroidectomy. This is an operation in which we are going to remove exclusively the abnormal tissue without visualization of the other glands by the surgeon. And this is a procedure that is performed under local anesthesia and with conscious sedation, so the patient doesn't need to be intubated. But it is mandatory for these patients to have a localization study before the surgery is done in order to be successful. And what are those localization studies? I'm not going to refer much to them. You have already excellent lectures on this yesterday. But you know, sesame scan and ultrasound of the neck, either alone or in combination and together with the SPECT-CT and 4D CT scans, which are new technologies, may help us to identify parathyroid adenomas. And you can see an example here of a sesame scan that shows a parathyroid adenoma located in the right side of the neck, as well as a sonogram of the neck that confirms the presence of the parathyroid adenoma. So grossly, how is that surgery? So you have a localization study that clearly shows an adenoma, then you identify the localization of the tumor here, then you do a minimal incision, you identify the tumor, you take it out, you close it, and the patient is quite happy, and he, in this case, she goes home immediately after surgery with a PTH value that in surgical evaluation, post-surgical evaluation, has markedly normalized. Big advantage of measuring PTH, as this one has a half-life of only 5 minutes. So in a matter of 5 minutes, we're able to confirm after surgery that the patient has had a successful surgical resection of the parathyroid adenoma. The levels of parathyroid hormone, in order to be successful, should fall at least by 50% when compared with baseline, and they have to fall into normal values. If they are not in normal values, we have to be careful. Despite of a very big fall, well, still the patient may have parathyroid disease. Let's talk about one example of an exception of this kind of procedure. Patients with parathyroid hyperplasia, multiple endocrine neoplasia type 1, multiple endocrine neoplasia type 2A. In those patients, we cannot really do the previous proposed procedure. For these patients, the options are usually a subtotal parathyroidectomy with a removal of 3.5 or 3.5 glands, and the total parathyroidectomy implies also immediate autotransplantation of the parathyroid tissue into the forearm. Why to do it into the forearm? These are patients who have a genetic predisposition to develop disease, and they will likely have, again, a parathyroid hyperplasia that will cause a primary hyperparathyroidism later. If you have autotransplanted the parathyroid tissue in one of the forearms and you know where it's located, if the patient has a recurrence of disease, you will be able to just cut a small piece of it, and you may be able to go back into normal values of parathyroid hormone and calcium. What is the impact of a successful surgery? From an objective perspective, patients who have had surgery for parathyroid disease are patients in whom, over time, you will see an improvement in bone mineral density. And you can see it in this graphic, in which in the y-axis you will see the change in bone mineral density in percentage, and in the x-axis the follow-up after surgical treatment in years. In green, you see the bone density in the radius. In yellow, the bone density in the femoral neck. And in blue, the bone density in the lumbar spine. And if you follow this graphic, you will see that in all these places, in particular in the first and second year after treatment, the bone density of this patient has markedly increased. Is this associated with a reduction in fracture risk? Perhaps. If you look at this complicated graphic in which you have patients who had not had surgery in the left side compared with patients who have undergone surgery, there is a relative risk to develop a fracture that is markedly decreased once you do a surgical procedure for these patients. In regards to the kidney, it's associated with a decrease in the rate of kidney stones by 90%. It may improve the glomerular filtration rate, and it may reverse also the osteitis fibrocystica that is responsible sometimes for bone marrow insufficiency. And from a clinical perspective and quality of life, these patients may have a disappearance of neuromuscular and neuropathic symptoms. So surgery in reality may have a huge impact in those patients in whom this procedure is indicated. There are, however, some patients that in clinical practice are quite challenging, patients in whom we are not able to do surgery because they have comorbidities that prevent that, patients who do not want surgery, or patients who have primary hyperparathyroidism in whom we are not able to find the cause of the disease. And in those patients, medications could be the only option to prevent complications and perhaps to help controlling the symptoms. What are the medications that we use for these patients? In order to protect the organs, we have medications that will work in bone tissue, and they include the estrogens, raloxifene, and bisphosphonates. All of them are anti-resortive agents. They may be able to lower the calcium levels mildly, maybe by 0.5 to 1 milligram per deciliter. They don't have any action on parathyroid hormone, but over time they may increase bone mineral density, and perhaps they decrease the rate of fractures in patients with this disease. And we have another interesting medication, a calcium-sensing receptor modulator, cinacalcet. This is a drug that lowers the calcium levels, it lowers the parathyroid hormone levels, and is associated with an improvement in bone mineral density. There are some clinical studies with cinacalcet, and this is an example of one in patients with primary hyperparathyroidism, in which in yellow you can see patients who were treated with placebo, and in green patients treated with cinacalcet. When you see patients that started to have hypercalcemia, when you put them on cinacalcet, the calcium levels drop. The patients with placebo continue with high calcium levels, and when you do the crossover and introduce cinacalcet, you may see that the calcium levels markedly decrease again into the normal values. And because of this study, cinacalcet is approved by the FDA in the United States for the treatment of parathyroid carcinoma, secondary types of hyperparathyroidism in the context of renal failure, and although it is not approved for primary hyperparathyroidism as we have it in clinical practice, sometimes we use it. So what are the conclusions of this lecture? Well, primary hyperparathyroidism is in reality a very interesting disease because it's an example of a disease in which the incidence and the clinical manifestations have markedly changed over time just thanks to the introduction of technology. The surgical and medical approaches of this disease have also changed because of all the knowledge that we have anticipated based on the epidemiological characteristics that we now know of this condition. And primary hyperparathyroidism is in reality very interesting and sometimes a challenging condition in clinical practice. So with this in mind, I simply finish giving some acknowledgement to the departments that participate in the care of patients with primary hyperparathyroidism at the MD Anderson Cancer Center. This is our outpatient clinic for bone and mineral disorders. And if you have any questions, please, I'm ready to take some time for those. I think we still have a few minutes for that. Thank you very much.